Good day, everyone. We are the Group A and we will be presenting to you a case assigned to us. Before going deeper with the specifics, it is important to dissect the case first and highlight the important parts. Firstly, the case is about a male patient in his late 30s who lives in North Carolina. He worked for a power company as presented in the slide. Secondly, the patient presented clinical manifestations including fever, muscle pain, cough, right middle lobe airspace disease, weight loss, chills, and night sweats. Thirdly, he doesn't smoke and had an unremarkable travel history with no prior exposure to animals or any risks for HIV. Fourthly, his medications include oral erythromycin, ampicillin, and antibacterial drugs. Fifthly, his physical examination revealed fever and an erythematous papule was noted on his skin. Moreover, his skin test, bronchoscopy, and various microscopic examinations with different techniques were all negative, except for silver staining of his skin lesion. It revealed the presence of large, round budding yeast with a broad base. By just reading the case, we may presumptively think of two general classifications of the disease. Either it is an infectious or a non infectious one. Under infectious conditions, the causative agent might be a bacteria like mycobacteria or fungi, especially the dimorphic and the true pathogenic ones. While under non infectious, it might be some sort of tumor. However, after a series of researches and analysis, the diagnosis of our group is blastomycosis caused by Blastomyces dermatitidis. And let us now begin the discussion.
The viral agent of the disease is Blastomyces dermatitidis, which causes blastomycosis. It is a dimorphic fungus capable of causing systemic infections in the lungs to the different parts of the body. The fungus is found in the soil and can be inhaled in cases of soil interruption, leading to pulmonary involvement. Symptoms manifested by the patient, such as low-grade fever, myalgias, and non-reproductive cough may be nonspecific, but the presence of the granulomatous skin lesion is highly suggestive of blastomycosis. The presence of a densely consolidated right middle lobe, a 3.5 centimeter subcarinal mass, and a small right hilar mass depicts pulmonary involvement or the primary pulmonary stage of the infection. Blastomyces dermatitidis is a fairly large, broad-based budding yeast which is a dimorphic fungus, therefore it can grow in mold and in yeast forms. The macroscopic morphology of B. dermatitidis in ambient environmental temperatures, ranging in 25 to 30 degrees Celsius, is in a form of filamentous mold that grows moderately slow, usually maturing in about 2 weeks, exhibiting cottony or downy texture. Its colonies produce white aerial hyphae on the surface and a light tan to brown color on reverse. B. dermatitidis in body temperature, or in 37 degrees Celsius, is in discrete yeast form that grows slow to moderate with characteristics of creamy, wrinkled, granular, to verrucose on the surface and cream to tan in color. On the other hand, B. dermatitidis in microscopic morphology produces septate hyphae with unbranched conidiophores of short, yet varying length extending from the hyphae. Its conidia are hyaline and are produced singly at the apex of the conidiophore or can develop directly on the hyphae. The conidia are unicellular, round, to pyriform or teardrop in shape which is approximately 2 to 10 micrometers in diameter. One unique feature of B. dermatitidis is a lollipop structure, which is a conidia at the terminal end. Lastly, it exhibits a broad budding base which is 4 to 5 micrometers in diameter, and the budding cell usually remains attached to the parent cell, separating only when reaching the same size as the parent.
Epidemiology: Blastomyces dermatitidis is endemic in the most of the area of southeastern United States, including Ohio and Mississippi River valleys, Kentucky, Arkansas, and Wisconsin. One out of 100,000 cases incidents are reported annually in the states where it is very common, like the state of North Carolina, Louisiana, and Illinois. Areas where the disease is hyperendemic exist in the north central of Wisconsin and the north region of Ontario, Canada. where the annual incident reported is 40 cases out of 100,000 people near the watery is more associated with an increased risk of blastomycosis. These epidemiology are based on the recognition and reporting of systematic cases. B. Dermatitis does not choose age, races, or even gender. It does not appear to directly affect the susceptibility of blastomycosis, as these factors represent variables that influence the likelihood of being exposed to this agent in the environment. Males, presumably due to the setting of their work and recreational exposure, occur more frequently. Adult men are more likely to develop systemic infection. Blastomyces dermatitis is usually recovered in the soil and in the decomposing matter like woods and leaves. They live in the environment as mold producing fungal spores. With this, people can get blastomycosis through breathing in or inhaling the microscopic spores. Hence, the reason why the patient was able to get the infected with the disease while he was cutting down tree limbs and tops. Half of the people don't usually develop symptoms when they breathe in the spores, but some people develop symptoms as the spore turns into a yeast and stays in the lung, manifesting lung infection symptoms, which is its primary stage of infection. In some cases, especially those who are immunocompressed, blastomycosis will spread to the other parts of the body like the skin, bones, joints, and the GIT. Symptoms of the blastomycosis includes fever, cough, night sweats, chills, malaria, arthralgia, weight loss, and a densely consolidated right middle lobe. Radiographically, it also resembles tuberculosis. Aside from this, a tender, raised, ulcerated, crusted erythematous papules may also be presented.
In order to confirm the diagnosis, a wide range of bacteria would be considered in the differential diagnosis based on this patient's clinical presentation. To effectively demonstrate the various creatures that must be considered, multiple methodologies are required. Mycobacteria were detected using an acid-fast stain. And despite a negative tuberculosis skin test and an unusual chest radiograph, M. tuberculosis and other mycobacteria must still be considered. Nocardius species, which could cause infections with a clinical presentation similar to this patient's, are detected using the modified acid-fast stain. And other specific stains, such as methenamine silver or periodic acid Schiff, can cause or can show the presence of fungal components in histologic specimens and are most commonly employed to stain tissues from extrapulmonary illness patients. Sputum culture has a good yield, and bronchial washings culture in pulmonary blastomycosis patients approaches 50 to 90%. And following the growth of the organism, a commercially available chemiluminescent DNA probe is frequently used to confirm the diagnosis or the identification. Although a particular urine antigen test for B. dermatitis is not available, Blastomyces is known to react or to cross-react with H. capsulatum antigen test, which could be helpful in the clinical setting. And B. dermatitis serologic testing, however, is both insensitive and non-sensitive. For the treatment of blastomyces infections, the most common one is through taking antifungal prescription medicine. One example of this drug is itraconazole such as Paranox, which is commonly used to treat mild to moderate infections. And for patients with a much more severe disease, amphotericin B is a treatment of choice, most especially for respiratory or systemic manifestations. And in other cases, both itraconazole and amphotericin B are combined to treat severely ill patients. And in terms of duration, it also depends on the patient's immune status and the severity of their infection. The course of treatment usually lasts for 6 to 12 months, and because of this long period, it is important for patients to really have follow up consultations with their physician to ensure the effectiveness of the treatment. And additionally, blastomycosis should not be attempted to be treated at home with self help or home remedies because a physician needs to diagnose, treat, and follow up with infected patients to make sure adequate measures are taken and relapses do not occur. Blastomyces infections can be hard or difficult to prevent, especially in areas where the fungus Blastomyces dermatitis is endemic. This is especially important to take note in areas like the South Central, Midwestern, and Southeastern states bordering the Ohio and Mississippi rivers in United States, and as well as surrounding areas of the Great Lakes and the St. Lawrence River in Canada. And because of this, the CDC recommends immunocompromised individuals to avoid exposure to these areas. This means that they must consider avoiding activities that are involved in disrupting soil in these places. And this is supported with the fact that there are no current vaccines available to protect individuals. Additionally, pets can get the disease and will manifest in similar symptoms as humans. But it is good to take note that infections are not contagious between animals and humans. So that ends our discussion for this case, and based on the information we have presented, the case is an example of a blastomycosis infection, as seen in its clinical manifestations, medical history, medications taken, and test results. It all concludes that the infection is caused by the Blastomyces dermatitis. And that ends our case. I hope you learned something from our video. Thank you.